Okay, ophthalmology first part. Extraocular diseases. Red eye. There are many possible causes of a red eye. It's important to be able to recognize the causes which require urgent referral to an ophthalmologist. And below is a brief summary of the key distinguishing features. Causes of a red eye includes acute angle closure glaucoma, anterior uveitis, scleritis, conjunctivitis, subconjunctival hemorrhage. Red eye, glaucoma or uveitis. So, how do you differentiate? In glaucoma, there will be severe pain, and halos will be there. Semi-dilated pupil can be seen. In uveitis, there will be small fixed oval pupil and ciliary flush. So, how can you just remember? You can just draw an oval pupil here, and here it will be semi-dilated pupil. So, this is for uveitis oval, and glaucoma, severe pain, halos, semi-dilated pupil. Okay, acute angle closure glaucoma. Severe pain may be ocular or headache. Visual acuity will decrease. Patient sees halos, semi-dilated pupil, and hazy cornea, as said before. Semi-dilated pupil here. And uveitis, as said before, acute onset. Pain will be there, but not severe pain. Blood vision and photophobia will be there. Small fixed oval pupil, ciliary flush. Okay, for scleritis, there will be severe pain. So it's similar to acute closure angle glaucoma, severe pain. Maybe worse on the movement and tenderness, maybe underlying autoimmune disease. The inflammation of the sclera, uveal tract inflammation, and this is the conjunctival inflammation. So this too can be severe pain. Halos will be the halos is something different here. Conjunctivitis will be purulent discharge if bacterial, and clear discharge is if viral. And subconjunctival hemorrhage will be history of cough or trauma bouts. Okay, so now what is meant by halos is this basically. Patient will see halos. Okay, back to where we were. And lacrimal gland problems. Okay, diagnosis cystitis is infection of the lacrimal sac, and there is watering eye called epiphora, and swelling and erythema at the inner canthus of the eye. And management is with systemic antibiotics. IV antibiotics are indicated if there is associated periorbital cellulitis. Okay. Moving to the next topic is congenital lacrimal duct obstruction. Okay, affects around 5 to 10% of newborns. It is bilateral in 20% of case. Features will be watering eye, even if not crying. Secondary infection may occur. Symptoms resolve in 99% of cases by the age of 12 months. Okay, blepharitis, it's the inflammation of the eyelid margins. It may be due to meibomian gland dysfunction. Common posterior blepharitis or seborrheic dermatitis. It's associated with seborrheic dermatitis we have studied before. Staphylococcal infection less common. Anterior blepharitis. Blepharitis is also more common in patients with rosacea. Basically, inflammation of the eyelids. Eyelid. The meibomian glands secrete all under the eye surface to prevent rapid evaporation of the tear film. Any problem affecting the meibomian gland, as in blepharitis, can hence cause drying of the eyes, which in turn leads to irritation. So, drying of the eye is caused by blepharitis. Features can be symptoms are usually bilateral, redness and discomfort, particularly around the eyelid margins. Eyes may be sticky in the morning, and eyelid margins may be red, and swollen eyelids may be seen in staphylococcus blepharitis, and styes and calazions are more common in patients with blepharitis. Okay, secondary conjunctivitis may occur. Softening of the lid margin. Management is softening of the lid margin using soft compresses. And so stye and calazion are actually in blepharitis, common in blepharitis. So give hot compressions, mechanical removal of the debris from lid margins. Cotton wool bud dipped in a mixture of cooled boiled water and baby shampoo is often used. Artificial tears may be given for symptomatic relief in people with dry eyes or an abdominal tear film. Okay, an alternative is sodium bicarbonate, a teaspoonful for this actually, in a cup of cool water that has recently been boiled. Okay, next is causes of mydriasis, that is large pupil. For cause of mydriasis can be third nerve palsy, Holmes LD pupil, traumatic iridoplasia, pheochromocytoma, Congenital. Drug cause of mydriasis can be atropine, it's used clinically, tropicamide, and sympathomimetic drugs like amphetamine, methamphetamine, anticholinergic drugs like tricyclic antidepressants. TCA can also cause this. So what's that's for the big people thing. Holmes are the people, dilated people. So, is a benign condition that most commonly seen in women. Benign condition is one of the differentials of a dilated pupils. DI. Unilateral in 80% of the cases. Dilated pupil. Once the pupil has constricted, it remains small for an abnormally long time. Slowly reactive to accommodation, but very poorly to light. Slow to accommodation, but very poorly to light. Okay. Holmes-Aldi syndrome is a association of Holmes-Aldi people with absent knee or absent ankle reflex. A cataract. It's an opacity of the normally clear lens which may develop as a result of aging, metabolic disorders, trauma, or heredity. Majority of cataract is caused by age or UV light. And systemic causes can be DM, steroids, um, infection like congenital rubella, and metabolic hypocalcemia, galactosemia, myotonic dystrophy, Down syndrome. Steroids can also be a cause. DM. And ocular can be trauma, uveitis, myopia, topical steroids can cause cataract. Okay, classification of cataract: nuclear, polar, subcapsular, and dot opacities. So first one is nuclear. So nuclear change lens refractive index common in old age. Polar localized commonly inherited lie in the visual axis, and subcapsular due to steroid use just deep to the lens capsule in the visual axis. And dot opacity is mainly common in normal lenses, also seen in diabetes and myotonic dystrophy. 4 types. Okay. Next is band keratopathy. It's a corneal disease derived from the appearance of calcium in the central cornea caused by calcium deposition in the Bowman's layer. It is an example of metastatic calcification which by definition occurs in the presence of hypercalcemia. So in hypercalcemia you'll see band keratopathy. Symptoms include pain and decreased visual acuity. And treatment the calcium can be scraped off the cornea or removed with a laser. This can restore sight, but it can also take a number of months for normal vision to return as the cornea will be damaged during operation. So it will take a while for the normal vision to return since the operation itself will cause some problem with the vision. This cannot be repeated too many times as it would make the cornea thinner. Okay, herpes simplex keratitis most commonly presents with a dendritic corneal ulcer, and painful red eye, photophobia, epiphora, visual acuity may be decreased. Okay, painful red eye, it's important. Photophobia is also there. Epiphora, visual acuity may be decreased. Fluorescent staining may show an epithelial ulcer, dendritic pattern of staining, as in this photo. Epithelial ulcer, dendritic pattern as staining. Immediate referral to the ophthalmologist. Topical acyclovir is the treatment. Okay, intraocular disease, sudden painless loss of vision. The most common cause of sudden painless blindness is ischemic optic neuropathy, ION. Most common cause. Example: temporal arteritis or atherosclerosis. Second can be occlusion of the central retinal vein, so vein first, and then occlusion of the central retinal artery third. Okay, vitreous hemorrhage 4, retinal detachment 5. So these are the 5 reasons of sudden painless loss of vision. Amaurosis fugax, so classically described as a transient monocular vision loss, that appears as a curtain coming down vertically into the field of vision in one eye. Sometimes it occurs as episodes caused by ipsilateral carotid artery disease. Okay, the most common cause ION, ischemic optic neuropathy, may be due to arteritis, temporal arteritis, or atherosclerosis, hypertension, DM, old patient. due to occlusion of the short posterior ciliary arteries causing damage to the optic neuropathy. So there is occlusion of the short posterior ciliary artery SPCA causing damage to the optic nerve. Altitudinal field defects are seen. Loss of vision above or below the horizontal level. Central retinal venous occlusion. Incidence will increase with age, more common than arterial occlusion. Causes can be glaucoma, polycythemia, hypertension. These three important causes. The diagram shows pale optic and optic disc swelling. Cotton wool. Okay, appearance: widespread retinal hemorrhage in all four quadrants, which vary in appearance from a small scattered retinal hemorrhage to marked confluent hemorrhage, marked dilated and tortuous retinal vessels, cotton wool spots, optic disc edema, macular edema, and retinal thickening. Vitreous hemorrhage may present. So this one we'll know later what is it talking about. Has to be retinal vein occlusion. So there will be retinal hemorrhages in all four quadrants, which vary in appearance from a small scattered retinal hemorrhage to a marked confluent hemorrhage, marked dilated and tortuous retinal vessels, cotton wool spots, and optic disc edema, macular edema, and retinal thickening. Hemorrhage may be present. Okay, central retinal artery occlusion. Retinal artery occlusion due to thromboembolism from atherosclerosis or arteritis. Features include afferent pupillary defect, cherry red spot on a pale retina. Okay. Appearance: diffuse edema makes the retina and arteries look pale. Perfused, so artery occlusion is pale, and the venous occlusion is like hemorrhagic. And features include afferent pupillary defect, cherry red spot. Okay. Diffuse edema makes the retina and the arteries look pale. Perfuse underlying tissues show through the thin fovea, giving classic cherry red spot appearance. Okay, so for this first image, this was about ischemic optic neuropathy, pale optic disc, and optic disc swelling. Okay, and vitreous hemorrhage cause can be diabetes, bleeding disorder. Features may include sun visual loss, dark spots. Okay, retinal detachment. Features of vitreous detachment, which may precede retinal detachment, includes flashes of light and floaters in retinal detachment. Okay, differentiating posterior vitreous detachment, retinal detachment, and vitreous hemorrhage. So posterior vitreous detachment, flashes of light, photopsia in the peripheral field of vision. Floaters often on the temporal side of the vision. Like this. Retinal detachment, dense shadow that starts peripherally and progress towards the central vision. So it starts from the periphery, comes to the central. Veil or curtain over the field of vision. And straight lines appear curved, central visual loss. Okay, vitreous hemorrhage, large bleeds cause sudden visual loss. Moderate bleeds may be described as numerous dark spots. Small bleeds may cause floaters. So floaters on the temporal side, flashes of light. This one periphery to the center, curtain over vision, central visual loss, and there is bleeds causing sudden visual loss. Okay, flashes and floaters are symptoms of vitreous detachment. Flashes and floaters. Vitreous detachment present in the long-standing diabetic patient is at risk of retinal detachment and should be referred urgently to an ophthalmologist. Okay, tunnel vision is the concentric diminution of the visual fields. Causes can be papilledema, glaucoma, retinitis pigmentosa, choroiditis, optic atrophy, secondary to Taves dorsalis, hysteria. Okay, macular degeneration. Okay, it's the most common cause of blindness in the UK. Most common in UK, so it's very important. Degeneration of the central retina macula is the key feature with changes usually bilateral. So bilateral change will be there. Traditionally, two forms of macular degeneration are seen: dry macular degeneration, wet macular degeneration. So dry is characterized by drusen, yellow round spots in Bruch's membrane, and wet characterized by choroidal neovascularization, leakage of serous fluid, and blood can subsequently result in a rapid loss of vision, carries worse prognosis. So dry and wet macular degeneration. This is the yellow spots, round spots, and this is neovascularization and leakage of serous fluid and blood. So updated classification based on fluorescent angiography. Early age related macular degeneration, non-exudative age-related maculopathy, drusen and alteration to the retinal pigmentation, epithelium RP. Late age-related macular degeneration, neovascularization and exudative. So it's just basically these are same different two groups: neovascularization, exudative. Previous it was wet, and this one is dry. Okay. So risk factors: age, most patients more than 60, family history, smoking, more common in Caucasians, the Europeans, female sex, and increased cumulative sunlight exposure. Features can be visual acuity decrease, blurred, distorted vision. Central vision is affected first. So, for example, like this, central vision is affected first, and then it goes away. Central scotomas, fundoscopy, drusen, of course, pigmentary changes. You also need to see what's drusen. Okay, so this one is drusen. As you can see, the yellow spots is a drusen. That's what you'll see in the macular degeneration, especially in the first one is dry macular degeneration, and the second one early age related macular degeneration. So drusen can be seen in fundoscopy, and general management is stop smoking and high dose of beta carotene, vitamin C and E, and zinc may help to slow down visual loss for patients with established macular degeneration. Should avoid smoking due to any cases of lung cancer as well. So we're going back to the thing: dry macular degeneration, wet macular degeneration. For dry one is there's no current medical treatment, and for wet macular degeneration, photocoagulation, photodynamic therapy, antivascular endothelial growth factor, anti-VEGF, like intravitreal ranibizumab. Okay. Next topic is RAPD, relative afferent pupillary defect, also known as the Marcus gun pupil, is followed by the swinging light test. So you check both the pupillary reflex. It's caused by a lesion anterior to the optic chiasm. So anterior to the optic chiasm is the lesion, optic nerve or retina. Okay, causes can be retina detachment or optic neuritis, multiple sclerosis, and pathway of pupillary light reflex is afferent to retina to optic nerve to lateral geniculate body to midbrain, efferent Edinger-Westphal nucleus midbrain to oculomotor nerve. Next is angular retinal streaks, are seen on fundoscopy as irregular dark red streaks radiating from the optic nerve head. The elastic layer of Bruch's membrane is characteristically thickened and calcified. Cause can be pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget's disease, sickle cell anemia, and acromegaly. Optic atrophy. We've already studied like many times regarding this term. So it's seen as a pale, well-demarcated disc on fundoscopy. You can see. This is the normal. This is the optic atrophy. This is the normal one. Okay, so it's a pale, well-demarcated disc on fundoscopy. It is usually bilateral and causes a gradual loss of vision. Causes may be acquired and congenital. Acquired cause can be multiple sclerosis, papillary edema, intraocular increased pressure like glaucoma and tumor, retinal damage like choroiditis, retinitis pigmentosa, ischemia, toxins like tobacco, amblyopia, quinine, methanol, arsenic, lead, nutritional vitamin B1, 2, 6, 12 deficiencies. Um, okay. Congenital causes Friedreich's ataxia, mitochondrial disorder like Leber's optic atrophy, so of course there lead mode like association of cranial diabetes insipidus, mellitus, optic atrophy, deafness, also known as Wolfram syndrome. So strictly speaking, optic atrophy is a descriptive term. It is the optic neuropathy that results in visual loss. So it's atrophied. Okay, next is retinitis pigmentosa. So this one is the opposite of macular degeneration. It primarily affects the peripheral retina, resulting in tunnel vision, and features is night blindness is often the initial sign. And funnel vision, the preferred term for tunnel vision, something like that. Since you see only the center from the funnel. Okay. Okay, the associated disease can be Refsum disease, cerebral ataxia, peripheral neuropathy, deafness, and echidosis. Usher syndrome, beta-lipoproteinemia, Lawrence-Moon-Battle syndrome, Kearns-Sayre syndrome, and Alport syndrome. So night blindness is often the initial sign, and tunnel vision is there. Fundoscopic findings can be mottling of the retinal pigment epithelium with black bone specule pigmentation is typically indicative of retinitis pigmentosa. So black bone specule pigmentation, black pigmentation in fundoscopy. Other ocular features include waxy pallor of the optic nerve head and attenuation, thinning of the retinal vessels, cellophane maculopathy, cystic macular edema, and posterior subcapsular cataract. CMV retinitis causes hemorrhage at the edge of the area of retinal necrosis. Congenital hypertrophy of the retinal pigment epithelium. Typical CHRP, gray or black depigmented lacuna found in 1/4 of the eye do not affect vision. And atypical one is white fish tail shaped bilaterally, affect the vision when there are more than 4 in each eye, associated with adenosis polyposis Gardner's syndrome to coloscope. Okay. Now an important disease, glaucoma.